Everyone. Welcome to our webinar. Today's guest is Dr. Rabbie Hanna. His journey in medicine spans over 24 years, marked by his dedication and expertise. He began his medical education at Al-Nahrain College of Medicine in Baghdad, Iraq, before moving to the United States for his residence and his internship at Detroit Medical Center. He specialized in obstetric and gynecology, furthering his specialization furtherly by completing Gynecological Oncology Fellowship at the University of North Carolina at Chapel Hill. He is a board certified in both gynecology and oncology and obstetric and gynecology. We are very happy to have you here today, Dr. Rabbie. We can learn a lot from your expertise and someone in your position in the medical field. We have many questions, of course, we can ask in the end. Make sure anyone who does have a question to write it in the chat, and we'll get to that later on. And we hope everyone enjoys the webinar today, and thank you.
Guys, thank you so much for inviting me to this. The reason why I love talking to medical students and people who are younger than me is because I truly believe in the statement that the Imam said, Zakat al-ilmi nashra, okay? And I want you guys always to think that any experience that you gain is a hiba min Allah for you guys, all right? And I can't tell you how many times I've seen big surgeons who always said, I was the one who was studying all day and night and working on myself to become a great surgeon or a great doctor. Okay. And one of the things in surgery is sudden turns of event. Okay. اللي قصده هنا هو بأنه قد يكون واحد يشتغل بعملية everything is going smooth and one small problem could go wrong, and that leads to so many issues. Okay, so that leads to problems with the patient. From my personal experience, and I've seen this in surgeons, and I'm going to admit in my own self that whenever there is kibar, ghurur, in what we do, you get a smack on the head from God and something goes wrong. Okay, either a scare in the middle of surgery or anything like that. So that's kind of a long explanation of why it's very, very, very important to acknowledge that all your abilities in becoming whoever you are going to become is a hiba and hidayah min Allah subhanahu wa ta'ala. Hence, what I would ask all of you, and this is a personal request, is anything that you learn from me or from anyone else, you pass it on, and it will become a sadaqah jariyah for you. Okay? So, and please, I want you guys to make this an interactive discussion, and that way we could learn more through different questions. And please do not be shy in asking any question. I don't care what it is. And I will tell you if I don't know. Okay? So let's start with the first major things in becoming a surgeon, an exceptional surgeon, and how you as a medical student now can work on yourself in achieving these goals. Okay? The first thing is going to be knowledge of anatomy. So master your anatomy. Yes, it requires a lot of memorization, but you could also understand why Allah subhanahu wa ta'ala created things the way they are. For example, the artery would be in front of, for example, the aorta is in front of the vena cava, more or less to protect it, rather than being really side by side to it. Okay, because the aorta is stronger in its wall than the vena cava. Okay. Now, so what to do as a medical student is rely on a certain reference that you would use from now till ever. So whenever you want to go back and study anatomy, you can go back to that same reference and you're used to the language it uses, you're used to its pages, to its illustration. And then as you move on, you're going to choose something more elaborate and enhanced. For example, if you have a desire to become a head and neck surgeon, master your current textbooks that you have. And then as you go on, you're going to find more surgical atlases for the head and neck. And then pick one of those and use it as your main reference as you go on. And anatomy comes from a lot of repetition. So, and the reason why we need to understand the anatomy is doing the surgical procedure requires you to know which structures are where. So through the anatomy, you can then become innovational in modifying surgical techniques to suit you best and to make you more efficient in your technique. And that's why I always say during surgical techniques, whatever you learn to do, you have to know the why behind it. For example, when I do a certain procedure, I have it standardized in my head. So every time I do it the same over and over again. If it comes that I use a new surgical tool, then I'm not going to do a new procedure. I'm going to do the same procedure using a new tool. So, and please pay attention to that. Meaning, an open hysterectomy is the same as a laparoscopic hysterectomy, is the same as a robotic hysterectomy. It's only using a different tool to get the job done. Okay? So when the steps are standardized, you know what you're doing. Any instrument that comes your way, you could use it to do the same surgical technique. Okay. Precision, meaning that you have to be precise in what you do and why you do it. And that is very, very, very important. And we're going to go through these points, okay? So you, through precision in technique and in anatomy, you will achieve the surgical outcome you want. Let's go back. I'm going to ask you guys a question. I want somebody to think philosophically. What is surgery? What kind of harm is surgery? Can anybody give me an idea? Any takers? Okay, so somebody by the name of iPad said a type of trauma. You are there. I need a specific word before trauma. And I'm going to change the word trauma later. Well, an incision is the type of, is part of surgery.
I raised my
Sarah?
hand, can I?
Oh, sorry, you raised your hand. Sorry, Habibi.
Yeah.
More. Okay, more.
Okay. In a simple terms, we can say it is destruct to reconstruct.
Okay, I love that. So it is destruction for reconstruction. Okay, I love that. Any other? So Abdullah said physiological trauma. Okay, physical trauma. So surgery is a controlled injury, meaning I am harming the patient in a controlled fashion to achieve a more noble goal. The less harm I cause the patient to achieve the same goal will lead me to a better outcome. Let's talk about an example. If I can do the surgery through a 7-centimeter laparotomy incision, it would be better for the patient than doing it through a 15 centimeter incision. if I'm going to achieve the same goal. It might require some more precision from me and some more patience, but it's going to be better. I had a 13-year-old patient yesterday. She had a 19 to 20 centimeter mass. I made a small incision, a lower transverse incision, and I suffered a little bit, but I was able to remove that mass after draining it. Where I've seen a lot of people say, oh my God, no, we have to do a big midline incision. In a 13-year-old, that's just going to cause some scarring in her life in the future. Okay? So, with this precision, I can achieve what I want. But again, I need to know my anatomy. I need to know my instruments that I use. All right. So with all of that precision, I can get the best outcomes ever. And with the precision, it requires from me how to hold various instruments, how to be meticulous about which instruments to use for which purpose. You will learn that as you go on. So write down a note that from now, start learning the correct names of the instruments that you will see, how to hold them, and all that. Okay? All right. Let's go to the other slide. Dexterity. So we use our hands a lot. In America, some surgeons have insured their hands, يعني عندهم تأمين صحي على إيديهم for millions of dollars. Okay? So if you're a right hand, start training yourself on writing with your left hand. Okay? Doing stuff with your left hand. And that is very possible because we know from neuroplasticity that we can create new connections in the brain that could help us use something that we were not used to before. That will allow you to be much more control in the patient and more flexible on which side to stand on or which side to work or which part of the abdomen or pelvis to work on, to your right or to your left. Critical thinking. So, one of my painful things in our mujtama is that we lack the ability to critically think. Okay? So, let me tell you what I mean by that. I'm going to give you guys a scenario. If you have an 80-year-old female with advanced cancer suspected on CT scan, and she has heart failure, uncontrolled diabetes, okay, and a diabetic foot. Do you think she's eligible for surgery medically? You guys with me?
Everyone in the chat is saying no, she will not be eligible for surgery.
Okay. What if I tell you, let's say if I'm the patient's son, and I say, دكتور أعرف راح تموت بس هو هذا حلها الوحيد. What would your response be? Okay, so Abdullah says she has to sign a consent form. Okay, so Abdullah, if I tell you that her mortality has a 60% mortality rate. Dania, I love your answer. Explain palliative methods. Exactly. So here we come and talk about, from a technical standpoint, I can go in and do the surgery. But how much would I add to her life if she lives through the surgery, and at what cost? Meaning that if I have a 60% mortality rate, then that means I have almost 100% of a morbidity rate. I could get her rid of cancer, but she won't be able to live the quality of life that she had. So at this point, we move to palliative care. Okay. So that's one of the things that we call a wise surgeon is a surgeon who does surgery with judgment. And that way, we can identify which patients really deserve the risk that they go through as compared to those who don't. So I prioritize my task after assessing the risk. So because my end goal is to optimize the patient care. Okay. And you will see a lot of these. You will see a surgeon who will say, دكتور بس هذا حلها الوحيد لازم أعطيها فرصة. When we know that the chances of dying are much higher than not doing the surgery. Problem solving is very, very important. We have to know the pathophysiology of surgical healing, of disease, of complications, so we can manage them appropriately. Okay? Let me give you an example. Are you guys mostly third and fourth years? Okay, so I'm going to give you an example. I did a hysterectomy on a patient, and during her post-operative day number 1, day number 2, she has low urine output. What should I do? Guys, did you get my question?
If anyone would like to unmute their mics to pitch in with an answer, it's okay, or you can write it down.
Yeah, completely okay. Okay, search for the problem. Murtada, is that Murtada, right, Mert? Or are you Turkish?
Yes, Murtala.
Okay, so search for the cause. Okay, what do you
Yeah.
think the most likely cause is?
I don't know.
No, think about it, Habibi. Just so, guys, in surgery, go to the basics. Low urine output could most likely be because of excess urine output,
Blood volume?
low volume. Excellent. So if I have low output, there's a good chance I have low. What's the opposite of output?
Yeah, input.
Input.
So it could be I'm not giving her enough fluid, she's not drinking enough. Now, let's assume that she has low volume, so she has low oral or low fluid input. Somebody comes and says, let's give her Lasix. Would Lasix increase her urine output?
I think it depends. If the
Mhm.
problem is in the let's say the volume side the patient,
Okay.
latex will solve it. But if the problem is in the kidney itself, that won't solve it, I guess.
Okay. So if the problem is in the kidney, Lasix might not work, right? And if the problem is in low urine output, it would increase urine. If the problem is in low volume, the output would be increased, but what's going to decrease? What's going to
The
happen?
volume.
So the intravascular volume would decrease more, and she will go into acute renal failure because we solved it in a wrong way. Okay, so here, if I see the volume increase, I didn't understand what's happening because I didn't search for the cause. I didn't think about it, and then we're going to have a problem here. We're going to complicate things more. Okay, so this is what I call problem solving in surgery is really simple because the body is. So sometimes I call a surgeon an educated plumber because you're dealing with tubes, blood vessels, GI tract, and you just have to understand what goes on. Okay. And of course, and guys, you're talking about shock and all that stuff. So yes, looking for the reason why the patient has low volume. Could it be shock? Could it be internal bleeding? Could it be sepsis? All that stuff is important. And if we use any medications, we have to understand in a problem-solving way and critical thinking way that what I do, what could it affect? If I don't solve the problem, the underlying problem. Now, skills and expertise. So, in surgery, one of the skills that I highly am critical about is how to communicate intraoperatively during teaching and during actual work. So we have to use a common language. So if I were to tell you, go up, go down, does that mean going up towards the abdominal wall, or does that mean going up towards the head? What words should I use instead of saying up and down? Ascent, anatomic landmarks, anterior, posterior. Okay, so I have to use what we all agree about. At any point, if I tell you to go anterior, you cannot misunderstand anterior, but you can misunderstand up. Okay, fog, Joa, right? Medial, lateral as compared to right and left. Right and left might work, but if I say medial and lateral, it's going to be more precise. So what I also encourage people who are learning surgery is when they explain the surgical technique, they will learn it more by verbalizing it and also verbalizing the correct methodology in the directions. Okay. Now, how do I develop the skills necessary? Respecting your time. I want you to watch as many surgeries as you can. But before you watch any surgery, if you could quickly read about it, just like a news, يعني قراءة جريدة about any surgical technique. Why is that important? I want you to read about the surgical technique itself and the potential operative complications. That is important. Why? The quality of questions and the quality of observation that you would have as a bystander would be more educated because they are based on some reading and not out of nothing, out of thin air. For example, if you watch me doing a hysterectomy and you say, hey, doctor, what is the most common complication in a hysterectomy? I'm going to tell you ureteric injury. And then your next question would be, what do you do if you cut the ureter? That is a very general question. It reflects that you have not read anything about the surgery. As compared to somebody else who says, hey, doc, my understanding is that ureteric injuries are the most common complication of gynecologic surgery, how do you repair the ureter if it is cut at the pelvic brim, if it is cut near the cervix? Okay, that reflects somebody who's read. That would give me more desire to answer the question. All right. So, and also, as you observe surgery, you will see different kinds of surgeons. Surgeons who you would want to imitate and be like, and surgeons who I do not want to become like that surgeon because they're so disorganized. So a lot of times you will learn what not to do, either because of the surgeon himself or herself, or because of the person who is assisting in that surgery. Okay? You will learn a lot just by observation. Now, medical knowledge, we don't have to go through that again. It's kind of explained from the above. It's what am I dealing with? What is the disease process? The pathophysiology of disease, the pathophysiology of healing, of complications, and the mechanism of action of any medication that I use. Now, technical proficiency. It should take you no more than 2 weeks to learn knot tying with your right hand, with your left hand, single-handed knot tying, right hand, left hand, two-handed knot tying, suturing, okay? Different types of suturing. There are so many books about it. There are so many Instagram posts about it, TikTok posts about it, and all that stuff. You could learn so many things from doing that. So I highly advise that you buy a small suturing or a small surgical kit. They sell it in Bab al-Mu'azzam for like, I don't know, 40,000 dinars. That could give you some knowledge of how to use the instruments. Okay? Because the most important thing is when you're driving, you want to know how you drive the car. Same thing in surgery. You want to know how to use those instruments. That's number one. Number two, as technology is advancing, we have a lot of instruments that rely on electricity. So understanding the basis of electrosurgery. What is a bipolar device? What is an ultrasonic device? What is what is coagulation? What is cut? When to use this? When to use that? All of those are very, very important. Now, I can tell you, nobody teaches basics of medical equipment in surgery, in medical school, or in surgical residencies, even in America. It all relies on, so that's why I want you to develop that curiosity where you go in and you say, wait a minute, this device is new. How does it work? What is its name? And if you find a similar device from a different company, what's the difference? Why is it cheaper? Why is it more expensive? Etc. When do I use this? Why do I use that? When do I use a suture? When do I use an electrical device? When do I use a stapler? Okay. How do staplers work? And sometimes even going back to look at the history of why these things were created and invented and how they were invented would also give you a background of innovation, because you will start thinking of minimizing the steps, and maybe you would come and invent something new. Okay. A lot of inventions came from people just by straightforward simple thinking. We talked about communication skills intraoperatively. Now we're going to talk about here communication skills as a surgeon with the patient and the family. And as I told you before, it is an amana that when you have a patient come to you and you're going to be their doctor, okay, that's amana of Allah subhanahu wa ta'ala. At the same time, it is an ibtila. What do I mean by ibtila is you will find different levels of education of various patients and their families, okay? Some people, by talking to them one time, they catch it. They understand what you're saying. Other people, you might require to repeat it multiple times. So here's where, and the reason why I say it's ibtila, because Allah subhanahu wa ta'ala literally is testing you during these moments. How much patience do you have when somebody asks you repeated questions, or might even ask you judgmental questions about your own work? Okay. So, and the only way that you could innately, يعني بالفطرة, learn this is put yourself in their shoes. So I'm a gynecologic oncologist. I deal with cancer every single day. I have a patient die from cancer at least one every week or two. So for me, it's become a lifestyle. But for the patient, most of them, they might go through their whole lifetime and have one or two relatives die of cancer. Okay. And they don't know how to deal with this. And death is so annoying because it is unknown. All right. So your goal in a disease process that they don't know about is for you to clarify and demystify that unknown for them and speak with them in the language that they understand. A saying that we had in America was, they don't care how much you know, but they know how much you care. I personally give my cell number to all my patients. I think currently half of Iraq has my cell number. Okay. I get tons of questions every single day. All right. Now, somebody might ask and say, ليش متعب نفسك؟ من راح يدفع لك؟ I'll go back to the ayah of the Quran Kareem, who Allah subhanahu wa ta'ala said, وَأَمَّا السَّائِلَ فَلَا تَنْهَرْ. And part of that means that somebody asks you a question, you give them the answer according to their level, and at the same time, always remember, if you help a human being in front of Allah subhanahu wa ta'ala, that carries a huge weight. Okay? So even if you guide them a simple guidance, it will carry a huge weight. What I do with my patients, with my old patients, when they come into the room, I stand up and I go kiss them on their hijab on top of their forehead, because I'm telling them, I consider you like my mother, like somebody I care about. Sometimes I joke with them so I can break the ice and tell them, hey, I'm just a normal person. Okay. So we can develop that trust and rapport between me and them. Okay. And at the same time, if there's something that I don't know, I tell them I don't know. Like, I have a lot of patients who come to me and say, doctor, I have breast cancer and I need to do X, Y, and Z. What do you think? I tell them, I don't treat breast cancer. I have simple information. It's not my area of expertise. So I will declare my ignorance. A lot of other doctors will give you their opinion and they'll move on. For me, no, because that is an ethical and scientific responsibility on myself. If I don't know something, I'll just say I don't know. Okay. But and at the same time, I will lead them to the person who knows, and I will spend that time in texting that person or calling that person or writing a consult for that person. I won't just say, حبيبي مو اختصاصي احجز على فلان عيادة. Now, so personal traits. We talked about the empathy, okay, which is living in the patient's shoes, making them understand. So I try to make each patient of mine as if they're my only patient that I have. So I make my patients feel that they are the center of the universe. Okay? Let's talk about resilience. What I mean by resilience is There will be days when you go through surgery and your first, let's say, and this has happened to me. I've had days where I've had 3 or 4 surgeries. My first surgery would be so tiring, or even with an intraoperative complication. Okay. Now, when I go to my second surgery, I have to develop that ability to start new with my second surgery and not carry the emotions that I had with my first surgery. All right. Or if there was a misunderstanding from a patient, I cannot let a single interaction with anybody control and make me reactive towards another patient. Does that make sense, guys? Are you with me? Are you guys there? Okay. Ali says yes. Okay, perfect. Because guys, I want you to interrupt me so we can. I want you guys to interrupt me. Guys, كهربائي من انقطعت.
Dr. Radia,
Yes.
I have a question.
Yes.
You've just said you have to control your emotion from going from one surgery to another. But
Yes.
for example, if you're just a new surgeon on this, like if you made a fatal mistake or whatever, the patient died. How could
Okay. All right, guys. So sorry for that technical hiccup. Let's go. أنت تسأل ونحن نجيب.
Is it okay if we start off with a few personal questions about your what inspired you for this career path?
Okay. So I loved working with my hands. Okay, so I grew up as a farmer, worked as a farmer for about 7 to 8 years of my life. I liked car mechanics, problem solving based on hardware. Okay, and then when I saw my first surgery during my medical school, I just loved surgery. I loved that, rapid action, getting things done. I personally did not have the patience of an internist. Okay. I didn't like to try something and wait. So that's what kind of led me to surgery. Now, the reason why I chose gynecologic oncology was because it so as gynecologic oncologists, we're not just trained in gynecologic surgery, but we're trained in urinary surgery, bowel surgery, and even in some plastic surgery. I don't do any plastic surgery now, but basically, my surgical skills are from the diaphragm to the mid thigh. So I even do my own groin dissections and all that stuff, and simple flaps for plastic reconstruction of the vulva. Now, so now here's where I'm gonna admit to you, it was because I wanted to do things by myself. I didn't like to call somebody to help me. Rather, I personally liked to be called to help other people in surgery. Okay. And that's kind of why I went to surgical specialty and specifically gynecologic oncology.
Okay, and we also have another question. It's about the robotic and laparoscopic approaches. We mentioned earlier that, regardless of the type of surgery, we always have the same aim usually. But we're very interested to hear about this new technique of robotic surgery. So could you explain to us your experience on working that?
Yeah. So basically, when we look at robotic surgery, so have you guys seen laparoscopic surgeries?
I personally have, yes.
Yeah. So for those of you who have watched laparoscopic surgeries, there's a lot of so the surgeon holds the instruments. Basically, so whatever the surgeon does gets translated at the same magnitude, if not a little bit more, to the laparoscopic tip. Okay, so if my hand is shaking, the instrument is shaking. Number one. Number two, the tip of the regular conventional laparoscopy is a two-dimensional tip. So it only opens and closes, and you can only rotate it with your external hand. It does not have any joint at its end. Number three, the visualization of most laparoscopies are 2D visions, so there is no depth perception. Okay. Number four, the camera is held by an assistant, so you have to be communicating with the assistant where to look, so you can't control the camera directly, and it's shaking because sometimes they get tired and just the function of the hand, it shakes. So in robotics, you have a 3D vision and a stable camera view, okay? To elaborate, let me pull up a robotic video just so you can see some technique, okay? Just so you can see how the instruments inside a robot or using the robot work. Okay, I'm gonna share my screen with you. All right. All right, can you see my screen?
Yes, we can see it.
Okay, so I want you.
The lymphatics can be seen through peritoneum as there is penetration of the fluorescence wavelength through 3 to 5 millimeters.
So you can see the robotic tip. So look at the image. The image by itself, it's stable, okay? And the tip of the robotic arm, the instrument, you can move it like you're moving your own wrist. So the precision of movement is way better. Look at the stillness of the robotic instrument and how detailed you can go. Now, also the image is magnified. It's digitally magnified. So you can see a lot of detail that you don't see with regular laparoscopy unless you go closer. Okay? So it's as if you're using your own hands, but at a more precise way. And even the ergonomics, يعني تأثير استعمال الروبوت على الجسم is much less intense as compared to laparoscopy. Because with laparoscopy, you have a lot of back aches if you don't position and you're standing up. In robotics, you're sitting down. Okay? So that's yeah.
Your comments down below. There are further questions about this topic. Someone was asking that, we've heard before that this does have better success rates than other surgeries. So if it is going to be established in Iraq, would that mean that this will also have a better outcome?
Inshallah. Yeah. So here's
one compared to conventional.
Yes. So now let's talk about the outcomes. So robotics itself is more expensive than laparoscopy. Okay. So now here we're going to develop a critical thinking. If I'm going to bring the robotic in, I'm going to spend more money because I'm going to spend more money on training surgeons to use a new instrument. The robot itself is going to add more cost to the patient. Do I have data that robotic procedures have better outcomes than laparoscopic procedures? Yes, we do. So we have a lot of published data, and you can do more difficult surgery using robotics than laparoscopic surgery because of the setup it uses and the instrument it has. Hence, I could do better. So pay attention to this. I could do better controlled injury, achieving better outcomes. Hence, it would give me the best way to serve a patient. Now, with all of that being said, not all laparoscopic surgeries deserve to be done robotically. What do I mean by that? If I can do a simple hysterectomy or a simple cholecystectomy using the laparoscope, in the same time I could do it robotically, so why add the cost? So now I'm going to go back to the amana. Is it my amana to increase the cost on the patient, especially the Iraqi patient who's paying extra money? No. Okay. Unless if I have a program that says, hey, Rabbie, do the surgery and I'm going to pay for it. That's a different thing. Okay. So I just look at this facial. It means that surgery could be surgery from overseas. Just okay. Yes, facial. So yes, there are companies now that are using 5G technology, so I could log in and do surgeries 11,000 miles away. Okay, that is very easy. All you have to have is connectivity. The robot that we're buying here for my institute, inshallah, we're going to be the first to introduce the robot in Iraq, inshallah, will have that technology. And actually, what they're working on is using a 5G technology with a minimum requirement of 40 megabyte per second. And now what that helps in is, for example, I could have a surgeon in Mosul who might call me and say, hey, Rabbie, can you please log in and guide me or take over the controls if we're using the same robotic system and maintain a stable connection, and I could do that surgery for him. So that is something that is very easily established out there, and a lot of companies who are working on robotics are doing their what they call to get CE certification to prove that this entity can be done without any difficulty and without any disruption or interruptions during the surgery. Amunur. Okay, Amor Rasul, you're the host. Go for it. Oh yes, exactly. So Faisal, see, medical tourism, our plans here actually at my hospital is to reverse that, is to bring people here from abroad so we can do their surgeries and everything, inshallah. Did Russo sign off?
No, I'm still here.
Okay.
I have more questions if that's fine. What about the challenges of studying abroad, and how did you overcome those challenges?
So, honestly speaking, I was very scared when I first left Iraq and study abroad because I was thinking, oh my God, they have more advanced teaching skills, advanced knowledge, and all that stuff. Okay. So I sat down for my USMLE step 2, I got an 89. And then I sat down for my step 1, I got a 98. Okay. And when I looked at what they had and what we had, frankly speaking, our teaching was really advanced in those ages. So all I had to do was deal with the things psychologically. So it was straightforward. Now, working in their hospitals and residency, that was completely different, okay? Because there's a lot of reliance on self-learning and self-teaching. We didn't have spoon feeding, and we had on uh, we had we had a lot of annual examinations and required a certain score to pass. So it was tough because the way the system is set up there is there's continuous evaluation of residents, and some residents actually quit because they couldn't handle it, and some residents were asked to stay behind for another year so they can meet their graduation requirements. Was it difficult? And I'm going to tell you what I taught my daughters when they were very young. Nothing is difficult. It's just a different shade of simplicity, meaning it's how you look at it. I remember as I was studying to become a GYN oncologist, the psychological fear was more intense than actual studying and working in itself. Okay. So I looked at people and I said, what's the difference between me and them? Hence, I said, if they can achieve it, I can achieve it. It might require less time or what, it might require more time. So I just have to go down to the basics. What do they know that I don't know? Hence, I would ask, how did you do this? What did you learn this? Why did you do this? So thank God, alhamdulillah, when I went into fellowship and I met with my mentor at that time, Dr. John Bogus, he was one of the gods of robotics. And I sat down with him. I said, listen, why did you do this procedure this way? Tell me your thought process. So I would kind of cheat from him and gain his thinking process and modified it. And that was very, very important. So I was asking a lot of questions. And of course, as much as I can, they would be educated questions. Faisal asks, the process of adapting to cultural difference between US and Iraq in terms of societal norms. And okay, so cultural challenges are going to be there always. And again, it's all about going down to the basics. Why am I doing what I'm doing? Going to the common grounds of dealing with any issue, okay? And as I told you before, when you think of stuff that you are doing this to help patients, liwajh Allah subhanahu wa ta'ala, and not to gain any fame, you will succeed. And they've said it, they said, if you work for your akhirah, you get the dunya as a side effect. If you work for your dunya only, you don't get your akhirah. All right? So promise me, if you put Allah subhanahu wa ta'ala as the wajha to do all your work, Allah يفتحها بوجهك, يسهل الأمور بطريقة you can't even imagine. And always in any difficulty, in any difference, go back to the basics, basic human interaction, basic human discussions, basic human communication, be emotionally intelligent, and you could achieve a lot of stuff. There's a lot of cultural sensitivity. For example, a lot of women don't let me do a vaginal examination on them. And I completely understand that. And sometimes I explain to them. So what I do here is I tell a patient, I need to examine you. So I tell my resident, I have a female resident who works with me, and I tell her, please examine the patient. If there is anything abnormal, I set up the patient, I tell her, I will make sure that you're covered and I'll come take a look. Okay? The majority of the time that works. And I tell them the usus al-shar'iyya that I have a rukhsa in doing that since I'm the only American board certified GYN oncologist in Iraq. Mr. iPad says, you mentioned that you give your personal number to patient. Okay, excellent question. It is time consuming and it is sometimes emotionally draining. So what do? I turn off when I want to sleep, okay? I have an ER who takes care of ER patients. So In my whole life, I have rarely required to deal with an ER patient in the middle of the night or an emergency situation in the middle of the night. The majority of the time, the answers can wait. So when I need to recharge, I'll take a nap. I'll turn off my phone, either put it on silent or on do not disturb mode, and I recharge. Okay, and then you will come to learn that which patients are, I'm gonna, for a lack of a better word, nagging, and that you could respond to them later, and which patients that you need to respond to them at a timely manner. And then you learn when to respond. For example, as I'm walking, I respond. As I'm in the elevator, I respond, and so on. Okay. Muhammad Saeed says, did I do any elective or observerships? When I was in America, yes. I did some simple electives and observerships, but those were not, that you got to learn the system that you were scared of. And now they're not allowing that anymore because of liability issues. So Faisal says, how is Warith maintaining its cost? Is it subsidized? Yes. So Warith, we are a non-for-profit organization. We are subsidized by Atab al-Husseiniya al-Muqaddasa, and we also have contracts with Wazarat al-Sahha and Wazarat Iqlim Kurdistan, where they send us their patients at a discounted price, but also generate some income for us. And we receive donations, and we're now actively working on an NGO entity called Munazzamat Warith al-Sahha al-Amma, in which we accept donations to help our patients. And we also have a lot of partners who help us in helping low-income patients.
Dr. Rabbie, may I add on to your statement earlier about some female patients not being very tolerant on you examining them?
Yes.
I wanted to ask if that has ever been an obstacle to you as a male doctor in the gynecological field, if that has lessened your popularity or priority when compared to other doctors just because they are female?
Well, so it's very, very difficult to quantify popularity. Okay. So you do the right thing. You can only do the right thing and respect the patient's wishes after you explain to them. Meaning that if a patient tells me, لا دكتور ما استحي أو شلون أو عيب أو ما أعرف إيش, I'm not going to just say كيفش خالة ماكو داعي. No. I explain to them why it's important. Because frankly speaking, you really don't need to examine all the patients. Okay? Through experience, you learn which patients you need to examine. And accordingly, those are the patients who you offer them an alternative if they refuse. For example, I had a patient the other day who I said she had a vaginal mass and the biopsy showed precancer, but the description of the MRI, the thickening was too much. So I told her, I need to examine you so I can guide of how to proceed. And she said, no. I said, okay, Khala, then what I would like to do is put you to sleep and do an examination under anesthesia and at the same time get a biopsy. So her son, I think it was at that time, agreed, and she agreed. And I told her that when you are put to sleep, my female staff will cover you and prepare you, and I'll come in.
Does anyone else have any other questions?
So guys, basically my main recommendations for you is organize your life, I'm sorry, let me go back to something that I completely forgot to talk about. Sorry. Surgery, to become an expert in surgery, requires a lot of time. Okay? It's going to be, I have so many times I've cried. Till this day, there are days that I cry. Okay? Because of the emotional burdens that I see of human misery that I see. Okay? I cry with patients. I cry with their families. Okay? I spend a lot of time with patients, helping them go through difficult processes. I spend a lot of time dealing with issues because some other doctors messed up with the patient. All right? It takes a toll on you. The actual training and learning surgeries and times in the OR and long hours also takes a time, takes a huge um, it puts a huge weight on your shoulders, responsibility and time away from family, and also time away from recharging yourself. So what I really recommend that you guys do is, number one, know when you are tired and take a break. Okay? If it's in the middle of the day, I use Salat and I try to make it on time to take that, even if it's a 5 minute break, just to kind of just a quick meditation, okay, during Salat. Recharging yourself either through exercise. Do not smoke. Please do not smoke, because I'm a smoker and I just got addicted to it. So do not use smoking as a method of comforting yourself. Do not use alcohol and all that crap or other drugs, please. Know and have a schedule in your weekly schedule, at least 4 hours, where you are doing something that gives you pleasure and not something related to medicine. Make time for family, for your social relationships, and then when you get married, make sure that the spouse that you choose to spend the rest of your life with understands who you are and what your goals are, and also arrange quality time with them, not quantity. Quantity is worthless, but quality time. Okay? Studies in America shows that the let me ask you this: how much do you think the quality time spent with kids among high achievers in America is per week with kids? Did you guys get the question?
It could be, not so much because they'd be very busy, like they're workaholics.
So how much do you think?
Not sure.
Give me a
I, I
guess.
I can't think of a number. But
Give me,
someone was suggesting 20% in the comments.
that's very 20% of the week? No, it was actually 15 minutes. Okay? 15 minutes. I can tell you myself, I was a victim of being a workaholic. Okay? In residency, I would work 120 hours a week. In my work after that in fellowship, the same thing. After that, the same thing. I can tell you, with I have two daughters. They're 21 and 20 now, and I was not there when they talked. I was not there when they walked. I was not there in majority of their functions. Okay, I actually got to know my daughters when they hit their late teens, more or less. Okay, because I was so far away. I didn't master the ability to develop that quality time. Okay, so that is something that I don't want you guys to go through, because I promise you, even if you're the best known surgeon, yada yada yada, you have everything that you wanted, it's not going to pay back all that time that you lost with your family. So make sure that, number one, your spouse understands who you are, that you guys grow together, okay? And that you spend quality time. What I mean by that is you make scheduled times. If you don't have kids, you make scheduled dates. Okay, there's the 7 by 7 rule, which is every 7 days you go out for a lunch or dinner together outside. Every 7 weeks you go for a short date somewhere local where you can spend the whole day together. And then every 7 months you take a vacation together and kick all the work aside. Okay, and there's a 2 by 2 rule. You can read that in relation books, but the whole idea is you have a quality relationship and you are there. And that you also have to learn to be emotionally intelligent, meaning that I don't want you to be one of those people who get back from work, you're exhausted from work, وبعدين طلعوها بالأهل. Okay, يعني you get back from work and your wife or your husband says, ها حبيبي شو ضايج؟ ايش بيك؟ شنو عبالك؟ يعني مو جراح النهار كله بالشغل، شنو قابل؟ اي لا شنو ضايج؟ وين الاكل؟ وين ما اعرف ايش؟ هذا حار، هذا بارد، هذا اكلته. That is bullshit. Okay? You have to be emotionally present. Okay? If your spouse is not a medical person, they're not going to understand your life. Okay? And you didn't because that most likely means that you either did not explain to them your life well or you didn't choose well. Okay? So if you were to call me at that time, I'll just tell you to divorce them. All right? But choose wisely and spend quality time wisely and grow together wisely.
Thank you so much for being here today, Dr. Rabbie. I think in spite of all the technical errors, I think this was actually one of the most inspiring and honest points of views we've seen from any doctor. I think you covered a lot of the personal life experience too, and we really do appreciate that. And it's been a privilege having you here today. I hope you also enjoyed the discussion.
Oh, I loved it. And guys, I used very little English. I love your English proficiency. And I'm really, really honored. There's a lot that I would love to talk with you guys about. If you guys are,
I think so too. I think we should have a second one day.
I could tell, because there's some stuff that I've learned and that I've acquired after looking at personal traits. Okay. And I've related them to positive psychology, emotional intelligence, where we where we were not taught things of what to do, how to deal with death, and how those have accumulated and caused a certain psychology of trauma, and personally speaking, and how I wish I had known what I know today back then, and that could have helped me a lot in how I would have passed a lot of psychological trauma in dealing with death, complications, and all that stuff. And I'd be more than happy to be on your arrangement again, inshallah. Additionally, if you guys are local, you are more than welcome to visit us here in Warith, inshallah.
Inshallah, maybe we can either arrange a second meeting. We do want to hear more things, or we can arrange a visit to Al-Warith, just as you mentioned, any of which would be a privilege for us. And everything about the pressure during the surgical operations and the problem with family time and the problem with traumatic experiences. I think this is all inevitable in the medical field. I do think it is just something we can't push aside, even if we do for a certain time period. It'll happen one way or another,
And
once or twice.
and let me tell you something. At the end of life, okay, what I want you to think is about on your deathbed. The question that I want you to ask yourself is, was I successful? And then with that comes, how do you define success? Okay. Was success through owning 3 BMWs? Was success through teaching medical students? Was success through whatever? So your personal definition of success, happiness. So success is happiness. What is the level of happiness? And here's where I say, let me give you an example about one experience that I've gone through. Let's assume today I own a Toyota Camry, okay? Because I'm a resident, my father bought me a Toyota Camry. Over the next 5 years, I become a very good surgeon. I now have the money to buy a BMW. I've paid my khumus, I've paid my zakat, I've paid my sadaqat and all that stuff. I have enough money to buy a BMW without sweating, okay? Is it halal? Yes, it is. Is it going to make me more attached to materialism? It definitely will. Because I promise you, the BMW that I'm going to buy today, and if I have more money, I'm going to buy the BMW 7 Series. And if I have more money, I'm going to buy, what else? What other cars are there out there? An Audi A8 or a Mercedes-Benz, I don't know what class, AMG, personalized, blah, blah, blah. Or I'm going to buy a big house with a swimming pool and whatever. Okay. So maintain a level of living that you are comfortable, and you're helping your family and society. And Faisal, yes, the entrapped of capitalist society, the American dream is car, home, vacation, retirement, and freedom.
Well, I think you worded that perfectly. Thank you once again for your time.
You're welcome. You're welcome, guys. Love you all.
And we thank you too, and we will write back to you about a second webinar or a visit if we have that plan.
And last thing is, you can become better than any surgeon out there. Okay? لا تنبهرون بأي واحد. They're just human beings like you are. All right, guys. Good night. Shams, I'll send you the videos, the 2 recordings, on what you want to call it, Telegram, okay? All right, guys. Good night.
Good night, doctor. Thank you last time. Good night, everyone. Hope you all enjoyed it.